All right. Welcome, everyone. My name is Makia Algamdi. I use she, her pronouns, and I'm an admissions recruitment specialist here at the Brown School. Thank you all so much for joining us today. I have the pleasure of introducing Philip Morata, who is an assistant professor here at the Brown School, and he'll be leading today's faculty roundtable session on clinical social work and substance use treatment. But before I turn it over to Philip, I would love for the audience to please introduce yourself in the chat box and, of course, to ask questions throughout the session. All right, I'm now going to turn it over to Phil to get started.
Okay, thank you very much for that introduction. Welcome, everyone. I'm excited to have this opportunity to talk with you a little bit about the delivery of clinical services within substance use disorder treatment settings, to talk a little bit about my work and how I structure my class, which you would be taking if you are in this track. Welcome to, and first off, I'll say congratulations on embarking on this really, really exciting chapter of your lives. I graduated with my master's in social work about 10 years ago now, 11 years ago, and it was a really exciting time getting a chance to learn about the delivery of services and to learn how to address and work with some very, very challenging social problems. And I think, you're all going to be at a wonderful institution with an unbelievable amount of resources, and a really, really unique focus on clinical social work. The Brown School has an unbelievable amount of resources that are available for graduate study, and really an unbelievable amount of selection and choices of coursework and the ability to customize. I mean, the combination between having a concentration and these different tracks, and multiple ways of kind of individualizing your education. And when I first arrived here, I was blown away by the amount of flexibility that are available to students in the curriculum here, and the range of coursework that can be taken. And so shout out to Morgan. I actually came from New York. 17 years I spent living in New York before I came here. I went to Columbia for my doctorate and for my master's degrees, and I practiced almost entirely in New York City. And it's nice to see where everybody's from here. It's a wide range of folks coming from all over the United States and internationally. So what I have planned for today is this is going to be very informal. And I'm getting used to doing all of this over Zoom and basically talking into a square box. So if you can turn on your cameras, it would be great. It would make me feel like I'm actually talking to human beings, as opposed to the abyss of the internet. So thank you. Hi, everyone. Welcome. Okay, now we're cooking. Now I feel like there's live people on the other end of the call. Okay, good. So I have some slides planned for you, just to kind of guide our discussion. I'm going to share the screen with you. It's really, this is an informal opportunity for you to ask me questions, and to get a sense of the flavor of how I teach my class. And then I can also talk to you some about, and I'm going to kind of defer to Makia a little bit because I'm new here. I came here in the fall, so I'm still acclimating myself to the culture of teaching. I see some familiar faces from the Admitted Students Day that I got to speak on. So it's great to see some of you following up. And okay, so I'm going to share my slides. Okay. Wait, hang on just 1 sec. Okay. So y'all can see this picture of me and okay, good. So that's my contact information. My name is Phil Morata. I go by he, him, his pronouns. And if you have preferred pronouns, if you can include it in your name, that would be just very helpful, because this is a really quick introduction. So I'm not gonna have a real chance to get to know you. So if you do have preferences around that, please let me know through your name tag so that I can make sure to be accurate with that. So, okay, so that's my contact information. I came to New York when I was 18 years old and lived there ever since. My entire history of practicing in social work has been done in New York City. A little bit about myself. I got my master's degree in clinical social work And afterwards, I just worked at the intersection of the criminal justice system and substance use for my entire career. And through clinical practice, which I'm sure, having worked with students for years now, in your first years out getting your master's, you have a lot of, you see a lot of the system from fresh eyes, from a fresh set of eyes. And I was really shocked with how dysfunctional the criminal justice system was when it came to treating people with substance use disorders. And I became very interested in understanding what we can think about as the collateral consequences of incarceration, the unintended consequences of legal intervention, essentially. So what my main focus on that is on HIV infection, infectious disease acquisition and transmission and risk, but also on social relationships, mental health, and substance use. So I decided to get my PhD a few years after I had been practicing, 4 years after I'd been practicing in the field. And so once I got in my doctorate studies, I focused on this exact topic. I looked at the impact of chronic criminal justice system involvement of intimate partners on their respective partners' engagement in drug use and sexual risk behaviors. And what my research found in my doctorate was that but both partners, it was heterosexual couples, both partners engaged in extra relationships outside of their intimate partnerships with their incarcerated partners. And it was very interesting because for many folks, they had reached these great agreements with their partners, that there was a lot of communication with their partners around this. But one area of my research that I look at is during this window following incarceration, there's a real spike. The year following incarceration, there's a real spike in terms of health risks. So people, when they get out of incarceration, and I can totally wrap my head around this and understand where people are coming from in this, they are craving intimacy. They're craving intimacy with other human beings. And so there's and the most extreme form of intimacy, which would be unprotected sex. And I understand, and in many ways I can wrap my head around that, because you're going from a setting of extreme deprivation to the community with a much more relaxed sense of rules that are being imposed. So that's what my research looks at. And I'd be happy to talk more about that. And the reason why I bring that up is that I have funding that's under review that I can pay master's level students to do research with me if they're interested in that type of work. So just a little bit of a pitch there. So there are 4 tracks here, if you're aware. I'm sure you're all aware: clinical social work, child behavioral health, integrated behavioral health, and then the clinical social work and substance use disorder treatment. And Ryan Lindsay is wonderful to work with, and he's the director of the mental health concentration. So I'm operating, today I'm wearing the hat of clinical work, right? I do some work in policy, I do some work in program planning and program development, but today I'm really gonna focus on the delivery of social work at a more individual or meso level. So I would be happy, and much of my work is in the drug policy reform space, be happy to talk about that, but today my conversation with you all is gonna be much more focused into the clinical area. So these are the required courses that you would be taking in the clinical social work and substance use disorder treatment track. Contemporary theories and issues in behavioral health policies and services, principles and practices in differential diagnosis, interventions and services in integrated behavioral health, and principles, practices, and services in substance use disorder treatment. That's the course that I teach. Or there's also some other folks who've taught it in the past, and they all have an enormous amount of experience. This track, so the way that this is structured is that you do a 300-hour foundation practice practicum and a concentration practicum for 600 hours. And your concentration practicum would be related to substance use disorder treatment. And one of the nice things about this track is that you can qualify for credentialing, which credentialing is one of the major strengths of the social work discipline. The MSW is perhaps the most flexible professional degree that you could possibly get. And then this designation will designate a specialty in substance use disorder treatment. You can also supervise case acts, which are the counselors, the bachelor level and sometimes master's level, but they're usually have lived experience, individuals with lived experience. And social workers play a big role in that supervision structure, and that licensure will enable that. So all of you are going to ideally be in settings that are focused on mental health treatment or advocacy. And advocacy is a huge thing in substance use disorder treatment. I teach skills of advocacy in my class. And it used to be that folks would not teach that as much in substance use disorder treatment. It used to be kind of like siloed treatment, drug policy, harm reduction, reform space would be kind of separate. And there's still remnants of that bias, of that kind of siloed approach. But I mean, hey, I'm wearing a harm reduction shirt and I do substance use disorder treatment services research. And so I do see a marriage between the two of them. And we'll talk some more about that. But I'm going to tell you a little bit about my class. I gave you the introduction, and so I kind of covered all this already. This is a little bit more information about me. I teach my course. So I'll give you a little bit of information about my course. My class is and I'm hoping to add another class in the coming year or two that we could teach on drug policy that could be opened up to everybody, like whatever your track is. But it would probably be within the public policy MPP program. But so I break my class into 3 sections, and I think these 3 sections are really the most important foundational skills that one needs to be able to practice substance use disorder treatment. One is you need to know the theory. You need to know what are the predominant theories that explain the progressive chronic deterioration that can happen when somebody forms an addiction. That is what the definition of addiction is: a chronic deterioration of functioning due to compulsive use of a substance, despite repeated efforts to cut back or stop. Now, that's really important to kind of grasp, because whenever you have a client that sits in front of you, you want to be able to say, why did this person start? That's your formulation in your mind. You're always, as a social worker, forming little hypotheses. Like, I think this person uses because they're masking trauma. I think this person is using because they have lack of stimulation. They're bored. They don't have meaning in their life. They feel a lack of purpose. I think this person is using because they live in a violent neighborhood and it's really scary, and that's a way of coping. So you have to be able to connect these, and there's multiple levels of explanatory factors, right? So you have the neurobio conditioning approach. So neurobio would be explain this through neurochemicals like dopamine and the reward pathway and the reward system. And then we also have what's very important is conditioning models. Conditioning models explain to us how cravings form. So cravings form when I'm conditioned to associate a response with a stimulus. So when I become conditioned to think that I'm going to get heroin every time I walk by an alleyway, I'm going to produce dopamine when I see alleyways, and I'm going to salivate. So that's conditioning. And then we're going to talk about cognitive explanations. These are the building blocks for what I think of as evidence-based behavioral interventions. So we're laying the foundation for the building blocks of what we can think about as behavioral interventions for this. And cognitive explanations. We talk about the negative thinking patterns and entrenched beliefs and core beliefs about oneself and about their drug use that lead to drug use. So we talk about shame, we talk about automatic thought processes, we talk a lot about how people use substances and when they're in this early period of recovery, there's a lot of automatic thinking that's happening, and how we can, and a recognition of that. There becomes a lot of recognition of automatic thinking patterns. Then we move into so classical and operant, yeah, exactly. So, but we look at, we're going to go way beyond animal models here. So conditioning models started out in animal models, but the newer research has shown that it's way more complex than that. So we spend the first few weeks talking about these different explanatory models. That's what I call these. And then we move on to another section, which is evidence-based interventions for substance use disorders. And here we talk about CBT, DBT, medication treatments, which is like buprenorphine, methadone, naltrexone, antabuse, compressate, the different meds that are used for alcohol use disorders. And we talk a little bit about what's being used now more for cocaine, but there's not a lot out there for it. But we talk a lot about opioid medications because that's the gold standard of what's available. Then I also talk a lot about assessment. So one thing you're going to need, and this is just a point of advice to all kind of newly minted or early career social workers, is you got to have some good instruments in your toolkit because you're not going to be fluid or well versed with many different types of instruments. So we're going to get, I kind of give a lot of different strengths-based instruments, which can include, you know, anything ranging from PTSD assessment instruments to understanding the functions of someone's drug use. There's a number of different interesting assessments that are used for that. We talk a lot about treatment planning. You know, substance use treatment planning deserves its own space, right? It's different than mental health treatment planning. It's different from a traditional psychiatric treatment plan. It's all going to be focused on what stage of recovery they're in and managing urges and cravings and how to restructure their social environment so that they're not triggered and how to manage urges, really. I mean, it's going to be a lot different than what you see in a traditional psychiatric treatment plan. And then I talk a lot about harm reduction. I am a harm reduction advocate. So I can operate in both these spaces. You know, I do a lot of work on the treatment end, but then I work with a lot of folks who aren't stopping. And so you may find that when you're working in your practice, so I also want to mention, you know, motivational interviewing is really important. So motivational interviewing is knowing whether or not somebody wants to change. And if somebody doesn't want to change, or if they're not in the right stage of change, I could give them any of these things and it's not going to work. And so it's about motivating people to be willing to change their behavior. It's very different than traditional psychiatric psychotherapy. Here you have to motivate. You do a lot of motivational work. I'm not saying you don't in other areas, but it's a lot in this field. And harm reduction is useful when you have somebody who isn't ready to change. If somebody's not willing to change, all you have at your toolbox is to motivate them with motivational enhancement, and then also to deliver syringes if they need it, to help them get naloxone, to help them understand what their risky scenarios that they're in and help mitigate that. If the person's using in alleyways or if they're using in bathrooms, how to use with other people. I mean, that's going to be because you don't want your client to die at that point. So you're working to keep them alive. We talk a little bit about 12-step, just enough so that you can interface with it. I think it's important because whatever your clients see as important, I believe in meeting them where they're at. And so when it comes to 12-step, I think it has benefit for many, 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 many people in early recovery and as a support system. And it's our job as social work. We're not welcome in that space. So that's why I don't spend a lot of time on it. It's a space that's for them to help themselves. But we need to know the language to interface with that system. So, you know, knowing things like working the steps, what step the person's on, and all that kind of stuff's important. One of the things that we also talk about that I think is a very important thing to do in the classroom is I really encourage my students to think about how their own lived experiences with substances influences and shapes their work. I mean, I think it's very important to know if you have a parent that's dependent, because we're dealing with one of the most common psychiatric disorders. I mean, it's in like the top 3. 21 million people in the United States had a past year addictive disorder. So that's like current disorder. That's very, very, very common. Some people say it's the most common illness is addiction. It's very likely that if you just look at those numbers as a percentage, that 4 or 5 of the people in this room are directly impacted in some way by substances. And so as social workers, we need to have a really strong grasp on those boundaries. You're going to see people when you work in substance use disorder treatment at the ends of their lives in desperation. People who will have literally died and been brought back to life. And then they go back out and die again and be brought back to life. So that will test your boundaries in ways that they have never been tested before. I've had students who've been in their placement and their clients have overdosed in their placement. So and this is the laboratory where you do that. This is the laboratory where you have supportive networks, where you have people you can talk to, where you have people in your immediate connection. You have my office door open to come into and talk to say, look, my boundaries are getting tested. I don't know what to do in this kind of situation. It's going to be more forgiving when you get into, it's going to be more unforgiving when you get into the field. It just is. You're going to be, your work is going to have more at stake in some ways. So I talk about this a lot in my class. I don't have students share. That's not I'm not forcing anybody to share their status, but what I am doing is I ask my students to think about it, because it's easy to get entangled in your client's problems. It's very easy if you share an identity with them. So it's very important, and I've counseled CASAC. It happens more often with people who are kind of certified addiction counselors, because oftentimes they have lived experiences and they don't even realize when that's going to get triggered. So they may have a client walk in the door that resembles a friend of theirs that died, or resembles somebody that, you need to be able to understand when it's happening. You're not going to be able to be prepared always to be like, I know when this is going to happen, but you do need to know like enough to be like, I'm feeling my boundaries tested. Like at one point I had a client who was 14 years old. I was working in youth services. She was 14 years old and she was engaging in prostitution. And it tested my boundaries beyond anything I could have. I mean, I'm old enough to be her parent, and it tested me in many ways about my limits. And I needed a lot of good supervision in the field. And so I think when it comes down to the work that you're going to be doing, a big piece of it in the classroom setting is going to be talking about some of these boundaries and how we're affected. And so also then we move on to sociocultural frameworks, right? I don't cover sociocultural theory first. I cover it when we get to this section on marginalized populations, because what this does is now we're looking at how the phenomenon of drug use in our society has been used as a mechanism of population control. So I'll say that again. Drug use in our society is maybe the biggest apparatus of social control, right? 45% of people who are incarcerated in jails and prisons are related in some way to drug use. So we talk a lot of, and whenever there's this apparatus of control, whenever there is a mechanism through which population control is occurring, it's going to marginalize vulnerable populations. And not only that, it's going to intersectionally do it, which what I mean by that is that populations that, for example, Black men who have sex with men who also inject drugs, that's a population that I've engaged with and worked with. There is going to be a compounding, what we call in public health, syndemic effect, which means that violence from the police, for example, or discrimination is going to increase both HIV risk and drug use. That's the definition of a syndemic, is one problem driving multiple problems, multiple epidemics. And so we talk a lot about, we spend over a third of the class designated for applications, because now I feel like the class is ready. I got to slog through the theory. I got to slog through some of the treatments. And then we can really get into the meat and potatoes of taking like, okay, well, now we know how the treatment services are delivered. Let's look at who they're excluding. Let's look at the problems with the system, and we take a real critical lens. But I don't feel like we're ready to do that until we have some stuff under our belt to be able to really kind of attack it. And I learn a lot from my students in that segment, because what we're doing here now is we're connecting the students' interests and passions to the subject matter of substance use disorder treatment. And that's my goal in that section of the class. So I cover as much as I can. There's a lot of populations that are disproportionately impacted by substance use disorders. And, co-occurring, we talk about. Criminal justice system, we spend some time talking about. There's a renaissance of research on substance use among LGBTQ plus populations, which is really exciting and interesting to read. It's very difficult to read when you hear how high the rates are, when you look at the traumatic factors that are linked to it, when you look at shame and the stigma, the impacts of stigma on accessing treatment. We look at all these different models. For that class, we look at trans-affirming CBT, which is a specifically adapted model of CBT for trans youth, specifically for treatments. There's some really interesting work being done. We talk about SAMHSA's rating scale, Substance Abuse Mental Health Services Treatment Administration. They actually rate agencies on how friendly they are to LGBTQ issues. So we look at some of that. Immigrants, talk about acculturation and the impacts of acculturation on drug use. Talk about women, specifically women in IPV, we spent some time talking about, and the use of substances and couples-based work and social relationships. And then we also talk a lot about trauma, because trauma is perhaps the most robust predictor of in the social environment of drug use. And intersecting traumas, which we know that once one person is traumatized, the likelihood of future trauma goes way up, and that's not the survivor's fault or the victim's fault. That is the fact that the social environment around them tends to be prone to trauma. So childhood abuse can then beget intimate partner relationship, and then after that you can see police violence. I mean, usually I'm working with a sample in New York City of women who were impacted by intimate partner violence, and the rates of intimate partner violence among women by male partners and female partners in the same individual is very, very high. We had a very large sample of bisexual women in that sample, and the amount of violence that is being reported from both partners in the same individual, a history of that happening, and it's like a lifetime history. It's very, very, very high. And then we're looking at that predicting overdose and drug use, and also engagement in services and a number of other factors. But anyway, so that's the kind of general topic structure of the class. We also do skills labs. So in every single class leading up to the sociocultural frameworks, one or two skills are actually role played and practiced. So we learn about assertiveness skills. We actually dig into the meat and potatoes of skills-based CBT and treatments for substance use disorder. So refusal skills, assertiveness skills, distress tolerance, relapse prevention skills, problem-solving skills. We cover a lot of different skills for your toolbox. We go through a manualized treatment that is basically a motivational interviewing / CBT manual. And so you get once you buy that, you have all those handouts. You can adapt that to any of your treatment settings. All right, I'm just going to spend 2 seconds talking about and then I want to get to questions. But just a minute talking about how I structure my assignment. I do one large assignment for my class, and it's a clinical case formulation. And that's all you have to do for the semester. And I break it into 4 parts. And the first part's a client description. You actually get to choose a client or make it up, one that interests you with all the details that you want to include in it. And then there's a theoretical explanation. So I want you to then see how this is mapping onto the sections of the class, right? So theory, you're going to tell me why your client used substances in about a 5 to 6 page paper. And then I want you to give me a theoretical explanation. So could it have been a relationship with, maybe it could have been stemming from their friendship groups that activated their risk of substance use, but it could also have been related to childhood trauma, or, there's a number of factors. Vietnam, there's some students have done Vietnam War vets or different veterans in their classes as well. So you could talk about why that might have happened. Then there's a lit review paper, which is going to be basically how you're going to tell me how you're going to go about selecting an individualized assortment of treatments for your client. So you're going to tell me, okay, well, I'm going to draw from this, 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 and then I'm going to build my own portfolio kind of treatment for this one client that we have. And then you're going to do a treatment plan, which is a narrative, essentially. It's going to give you practice writing in clinical language. And I give feedback to each of those, and you can revise it and then submit all of that in the final paper. So that's how I structure my class. And I'll tell you, many students have used this as a writing sample when they're on the job market. So they'll use that to send in to employers to show, because you'll see when you do go on the job market eventually, for clinical jobs, they're going to want experience. And this is the conundrum that a lot of social workers face, is that early social workers oh, I don't have any experience. I tell all my students, apply anyways. Apply anyways. Just ignore it, put in your experiences, and send in this to show that you have some clinical training. And I had a student with 0 experience get a job at the Betty Ford Clinic right out, which is a very good, one of the most outstanding substance use disorder treatment programs in the United States. So it's all designed to help you get a job. I mean, that's my end goal. And really because I want to increase people helping people with substance use disorder. So as part of my passion to helping people in this area, in this space, I feel like if I can get some of everybody who's, you know, some of the folks who are getting their masters to go into the field, then it will help generate, especially young people with progressive like ideas around substance, you know, how substance use disorders function, and to get some of the, I don't know, just to be blunt, to get some of the old blood out in terms of like old philosophy that needs to go. In terms of, I want to bring in new blood into the social work field, I mean, into the substance use field. So that's it. That's all I got for you. And then the rest of the class, I really want to, if you have questions or comments or you know, this is your time.
I have a question.
Yes.
Hi, I'm Amalia, she, her, hers.
Hi, nice to meet you.
And I just want to clarify, did you say towards the beginning that this is required for the concentration, is that right?
Mm-hmm.
But can people outside of the concentration take it?
Yeah, I've had students from occupational therapy take my class.
Oh, great.
Yeah, from like a whole different school. So yeah, so I mean, you would have to work out how it fits into your sequencing, and there might be some like guidelines around like when you can take it. But I've had students from pretty much across the board. I mean, Makia, correct me if I'm wrong here. Do you know?
You can definitely take it by using your elective courses.
Electives, yeah.
Yeah, you have up to 9 to 11 elective courses that you can use towards those classes that you're interested in taking.
Great. All right. Thank you.
So to respond to the question in the feed, we spend our last class talking about the horizons of, you know, what's the new areas around diagnostic categories that are kind of being like debated for inclusion. We definitely talk about the role of food in addiction, especially around early sobriety, around sugar intake, and around how food can be transferred over pretty easily. Like addictions can go, when somebody stops drinking, you see a big spike. I mean, that's why there's the stereotype of like people in AA getting slices of pie at the diner. I don't know if you've like, or like meeting up for sweets, or if you've ever been to an AA meeting, or if you've ever seen people in an AA meeting, they got candy everywhere. It's like crappy cookies are just like all over the place. It's just a common thing. Church, it's usually in a church or spiritual setting. They usually have a lot of, but it's part of that is the connection to when somebody has an urge or an impulse to drink, sometimes they turn to food as the lesser of that option. Now there's other food addictions and also pornography. So in terms of sex addiction, that has been rejected in the DSM a number of times. We do talk about hypersexual non-paraphilic issues. So what that is the debate around sexuality or sexual behavior being included in the DSM has been debated every single round of the DSM. And it has not been included because it cannot be parsed away clearly enough from other illnesses. So they can't distinguish it enough from, like, for example, hypersexuality just as somebody's preference, right? So what if somebody is hypersexual in their personality, but it's not causing problems for them, right? That's always been kind of some of the issues around the DSM. I personally do think that there's a strong connection between, whenever there's a dopamine response, there can be an addictive possibility with it. Whether or not it's its own, like it's gonna rigidly map onto the DSM, I'm not entirely sure if we're there yet. But I think that when somebody has what's called a hypersensitivity to dopamine, which means they have like low dopamine production, or they are, you know, sensitive to dopamine and neurochemical production, I think there's anything can be addictive in that. And so there's work can be addictive, exercise can be addictive. You see people forming unhealthy relationships to a lot of, and so part of working with a client with an addictive disorder is helping them understand how their addiction manifests in many ways of their life. Their addiction is not going to just manifest in the drug that they're using. They're going to oftentimes, what you hear with your clients when you talk to them about this is that that's my addictive mind speaking. And that can happen with sex. And dating in general for people with addictive disorders is terrifying in the early stages of sobriety. It's you'll hear it if you work with anybody who's newly sober and they're thinking about dating. It's scary, not only because of the emotional trauma, emotional sensitivity. So there's a hypersensitivity to emotional responses, but also because of unhealthy relationships to sex in the past. Also, people fear their date will be consuming alcohol when they get there. If you think about the way Tinder dating and the way dating is done now, people meet up at a bar for their first date, oftentimes. So it's definitely challenging. But I don't, and so anyways, that last class is devoted to gambling. I talk a little bit about like what the proposed criteria are and some of the treatments, but there is Sex Addicts Anonymous and there are treatments out there and we talk about it. I also devote the other half of that class. It's a 3-hour class. So I devote the other half of that class to the use of hallucinogenic medicine to treat substances. And how now we're seeing a rise in psilocybin production being used in clinical trials. And I actually believe that social workers are going to be tasked with what's called psycho-integration, which what that is after there's a profound psychedelic experience, which is what psychedelics do. There's 2 ways of taking psychedelics: microdosing, which is called psycholytic approach, and there's also the psychedelic approach. The psychedelic approach, person is supposed to have a mystical, profound experience, and then they work with a social worker or psychologist to integrate what that experience means for them, and that's called psycho-integration. It's done a lot with people who are chronically ill or dying of cancer or trying to accept their fatality that's coming. They will take hallucinogens to cope with that. I'm seeing some questions flying through. Let's see if I can get back to the last one. Okay, I think it's in the family system. Yes, we have a class on that. So I devoted an entire class to social relationships. Half of it's family systems theory. The other half of it is couples-based and behavioral couples counseling and working with the parents or a couple, committed couple. We talk within that. I don't spend a lot of time talking about drug treatment for children. It's another class that I'm thinking about if I'm going to teach a new class. One of them may be substance use disorder treatment for adolescents and youth. It's much different when it comes to working with children. I'm sure if you're interested in this, you probably know this, that it's much more preventative as opposed to treatment for the disorder. You're doing a lot of like redirecting. You're trying to say, okay, you're using, why don't we get you involved in all these activities that can help prevent it from getting worse down the line. That's why they call it preventative services in a lot of home visits that are done with kids that are using substances. Like we do multi-systemic therapy. We talk about that, which is probably the treatment that one of the treatments you're mentioning. So yes, could include this class. I'm looking at here. Question. Could I include this class in my individualized concentration? I'm hoping to develop a concentration in LGBTQ health and wellness, and it sounds like this class would be a great fit. Makia, can you chime in on that?
Yeah, absolutely. You can do that. Around early June as well, you'll be meeting with your academic advisor who can help you sort out your course sequencing and registration. So yes, you can definitely do that.
Okay, great. Can you talk a bit more about your policy work in the criminal justice system as well as possible research opportunities? Yeah, so what I'm doing right now is as part of what you do in your first year of being a faculty member is you apply for funding. You apply for opportunities to collect data and to work in the community. Much of my work around policy, so I'll say I will know what those funded opportunities will be in June and July. And I'll put out a notice and that'll say looking for a master's fellow to work with me on a number of different projects. One of them, I'll just give you an example. There's one of them is looking at trajectories of engagement in buprenorphine among people re-entering the community from prison who've been incarcerated to help, and looking at the role of their family members and intimate partners in sustaining their recovery in the community. So that's one where I have a funded opportunity for a student. Another opportunity is we're doing some work looking at the risk of overdose among people who are being released and re-entering the community from incarceration. And so I'm in the early stages of developing an intervention to have community health workers and be trained to be able to link people to care as they're re-entering the community. So that would open up opportunities. And I'm also doing some HIV work to train community health workers to be able to increase engagement and care for the hardest to reach populations of people with HIV. And so that's a little bit more broad. Now I'll just speak for a moment to my policy level work. So my policy level work really, it really centers around working to provide evidence to state legislatures and to states in general, and key stakeholders in states to adopt innovative systems of care. So innovative systems of care can be, for example, a pre-adjudication referral to treatment before somebody is even charged through the criminal justice system. Much of my policy work, so if you think about the criminal justice system as a pipeline, and at each level of the pipeline, there are faucets that can be turned on to prevent people from getting through that system. My goal is to make those valves more equitable, first and foremost, but also to prevent people, to try and get people to not be as far along in that system as possible, to go farthest away from the criminal justice system. So I've done, most of my work has been done with the police. So trying to get police on board with alternatives to aggressive policing, alternatives to drug law enforcement that is aggressive, that it involves, like, for example, more true public health approaches to working with police and the criminal justice system. What I have found is, there has been a lot of traction in terms of drug law reform, but there has not been a lot of traction in terms of police-public interface. The interface between the police and the public. You're still seeing people who have substance, you can even look at the George Floyd case. I mean, that person had a substance use disorder, and we're seeing it in the news that somehow his fentanyl addiction matters. How somehow that matters in the debate of whether or not that was okay for a police officer to put his knee in the back like that. So I try to participate in that discussion by saying many of the folks who are victimized by the police, many of the folks who are subjected to a systemically racist system are people with substance use disorders. Many people, I mean, an overwhelming number of people who are abused by the criminal justice system are people who struggle with substance use disorders. I'm looking at the media portrayal of this case from the lens of a professor who teaches this subject, but B, also someone who's in recovery. I mean, I'm in recovery as well. So when I look at the privilege that I hold and see that somebody is being treated like this, when we share the same illness, blows my mind away in a bad way, And so my policy work is activism, really, but I'm using science to try and help move that needle. To try and move the needle in a way that is positive for people. That does not, I want to live in a society eventually where it is not the subject of conversation of like, well, all this information that's coming out around him having had overdose deaths in the overdose reversals in his recent past. All of this is being used to discredit the claims that police officer was violent or caused his death, I should say. There's all this information that his addiction is being used by the defense to smear the narrative, that this was not right, that this was unjust. And when you look at it through that lens, it's infuriating because it's stigmatizing to all people who use drugs, that it's like somehow police violence in that way is okay. And evidence in favor of it being okay is that he overdosed recently, when in reality, that's a tragedy when you think about it. So that's kind of how I do it. Not to give a long-winded answer, but I integrate activism into my scientific work. And you will see those emails get circulated through the department. So I'm looking for more questions. You can also chime in. You don't have to do them in here. I like the human interaction too. So it's like,
I'll chime in. Can you hear me?
Yeah, and then I'll go back to the questions. I'm going to kind of go back and forth to kind of motivate people to ask questions. Yeah, please. I remember meeting you in the student.
Yes, I'm Phil. Nice to meet you, Phil.
Hi, and I'm Phil as well. Yeah.
Yeah, no, I know. It's great. So no, I'm really interested in taking your course because I wanted to come to the Brown School for this exact reason, because I was affected personally by loss. I'm from Vancouver, and we had that big fentanyl wave that came through in 2016, and I lost my best friend from high school to fentanyl. And being a gay man, and I've had a lot of good friends in that world due to crystal meth addiction. So I've been sort of touched in many different ways, and
Wow.
I'm very, very interested in sort of helping those communities, especially the LGBTQ plus, like crystal meth, opiate, it's sort of ravaging all corners of the country, especially where I'm from, the West Coast, Vancouver, and friends out in Toronto, New York. So when we take this class, are we able to, like you said, what was that term, cross-section? That was the term? So the cross-section of like being gay.
Intersection.
The
intersection. Yeah.
Sorry, intersection.
That's okay. Yeah.
So are we able to focus, if we have a particular community that we want to focus on, we're gonna do that? Like sort of work on,
Yeah, so that is the focus of my class. I believe that students learn better when they have that opportunity. Right. And I think it also helps cultivate your passion. So that's a big thing that and thank you for sharing your story. I think it's a great motivator. I mean, it's a strong motivator, what you're describing, to go and help people, and inspiration to channel that energy. What I do for my class is what I kind of reflecting my general philosophy on what I think graduate school is best for. And it is for learning, of course, but also honing your passion. Like, you gotta be, to everybody in this room, if you're not passionate about this, you probably don't want to go into this field, because it's gonna be hard, and it's gonna be unforgiving in some ways. And it's not gonna pay you as much as you deserve, just to be completely blunt.
Right.
Passion is what's going to get you through the end of the day. And so that's also why I love this field so much, is that when you go into this field, you're surrounded by many passionate people. And the people who are not passionate, you tend to see turnover a lot. But people who are really passionate, there's a lot of room to make a difference. There's a huge amount of room to make a difference. And so on a micro level, my class is designed to kind of reflect and mirror back that piece, which is to say, I push students in the very first couple weeks to pick a client in their mind that reflects that passion, that reflects what they're most interested in. And I think if you adopt that philosophy generally throughout your program, and just cater your classes to, and be a very strong advocate for yourself by saying, this is what I want to take, this is who I want to help, I don't want that placement, I want this placement. Like, not telling everybody to cause trouble here. I'm just saying you got to be a good advocate for yourself. And that's and so not only does this class offer that, this program is designed to do that. And you would need to, and if times you're not feeling like that's immediately fulfilled, it's the time to talk to someone, because there's people around that can make that happen.
Right.
And do you have another question? Are you gonna?
No, that was great.
Okay.
And also introduce myself.
Welcome. And I look forward, I hope to see you. And Vancouver is a place where they had the first syringe safe injection facility.
That's right. I wrote that in my intro essay about that. Yeah. No,
it's very progressive, and very much it was back when I was getting my master's, is when they had the first safe injection facility conference, which was around that very topic. And it was in
2000, when was that?
The conference might have been a little after it was made, but this was back in 2008.
Yes.
Yeah. So other questions, I'm going to bounce back to the feed and see if we can get a couple of these questions in that are coming in here. So my name is Al, I have a psychiatric training experience for MPH. Okay. And of course, yes, you can. Oh, as part of your practicum, I don't know, but I think you can still just take the course. Practicum. I don't know if it's part of a practicum experience, but I think it would be a course, like an elective, like Makia had mentioned. Yes, we will cover a lot of community-based. That's what we talk the most about, community-based models. Because even though they might be involved in the justice system, oftentimes they're being mandated to a community provider. So you'll see many clients. That's the main mode of delivery. Especially since we're not arresting people as much we're arresting them but not putting them in jail. The rates of people actually going to prison and jail for like substance use disorder related that's much lower. But people going for more levels of possession, you do see that. But for the most part, I'm going to be focusing on the community because that's the most effective way to do it. Okay, yeah, so that's it. Okay, that's all the questions there. Are there other people in the last, you got about, what, 10 minutes left, right? Goes till 1. You have my email too, so you're more than welcome to shoot me an email. And for those of you who did email me, I'll be getting back to you soon. I'm in the process of grant writing, so things have been a little slower. This is the busiest time. You'll learn when you start your studies. This is the busiest time for students and professors right now. This is middle part of April. It's always a nightmare. So, other folks.
If you don't mind, I actually have another question.
That's fine, Abby. Sure.
First of all, hi, my name is Abby, and I go by she, her, hers, or they, them, theirs pronouns. Thank you for answering my first question. Mine's kind of a second part to that question. So could you speak a little bit more? You kind of introduced this topic, but to the difference between substance use in adults of the LGBTQ plus community compared to children and teens. I guess I'm trying to decide if I should make my concentration more specific to one of those communities, whether it be younger people versus older adults or kids, and was just kind of wondering, especially if there will be a second class, if you anticipate a second class that you'll be teaching that will more specifically deal with the topics of younger people, kind of what your input is on that.
Thank you for that question. That's interesting. So what I will say is you have to, even in my adult, like even teaching, the issues of substance use in LGBTQ plus populations, I talk about child development, because when you listen to the lived experiences and the stories of addiction from this community, and that's what I do. I just, this comes from listening to what I hear on, from working, is that it starts around a younger age when gender and sex identity and orientate and all of these issues are coming together. So personality development plays a huge role, right? So we know that some of the literature on gender identity and sexual, orientation, these are two separate issues, right? Sexual expression and gender identity. But when it comes to trans populations specifically, and I'm just speaking to what I've heard, is that a lot of folks say that I felt shame, I felt a lot of self-loathing, I felt a lot of discomfort, I felt a lot of dysregulation internally because of invalidation, chronic invalidation. I felt a tremendous amount of shame from my family. You can hear it related to a negative coming out experience or a forced coming out experience, whether it be outing as sexual orientation or outing as a gender identity, being outed in a way that is not their construction. Creates long-lasting effects, and it can affect suicidality. It can affect drug use. And the thing that makes me so sad when I hear these stories or upset is that it's internalizing. These feelings become internalized. So it's not like you see people go out and become violent as a result of this. They go out and they harm themselves. So they drink and self-destructive behavior. And so I think you're going to need to, if you're going to go the adult route, you can't ignore the childhood context. You just can't, because much of the work, and this is a population similar to other populations where I'm not forward facing. I work with communities, but I'm not the one that's going to sit as much in a therapeutic setting. I would help work with specialized folks who know the lived experience. And so many of the folks in those treatment settings are from the LGBTQ plus community, and I work with them to help the delivery of services. But I'm not going to step into that space because of how important it is to understand the story. You have to understand the story. And so the story is very common, and you hear this, a lot, is shame and internalized negativity are some of the kind of predictors of drug and alcohol use. Childhood work is really important. So I actually would probably advise you, if you're really interested, maybe you want to look into going the adolescent route, because it's so preventative. We need it. We need it. By helping a young person make sense of these issues, you're preventing so much down the road, so much sadness, so much struggle, so much in terms of drug use and addiction. It's not a clear, it depends. I mean, you'll figure it out. Like as you get more situated in the program, I think you'll get clarity about something like that. When do you have to decide on that, Makia? I think you have a whole year, right? Or do you start, when do you start having to commit to the direction that you're in? Does it like start out foundationally or does it start specialized?
Yeah, you start out your first semester with your foundation courses. That gives you time to explore what you like and dislike. And then by your second semester is when you decide what concentrations you want to choose.
So I would say your first year, feel it out a bit.
Mhm.
Like feel it out, kind of see what really interests you, where where your placement is maybe.
Awesome. Thank you so much.
Sure. Happy to help. You know, as difficult as the state may seem, the city is pretty progressive of St. Louis. And so, I mean, these issues are difficult, and we talk about this some in my class, but a lot of the questions that you've been asking, we do kind of have to factor in that we're in a pretty hostile policy environment in terms of state law and state funding. And, you know, there are services for LGBTQ folks in the city, but they're minimal, they're limited. They're very, very, very limited. And many people are accessing services through mainstream approaches that what the SAMHSA would designate as LGBTQ naive. So SAMHSA has ratings for this. Like I said, most of the services that are going to be delivered are going to have no specialized, no recognition. It's invisibility, and SAMHSA actually says that's bad. Like refers that as less than ideal, because what that means is that there's an invisibility. It doesn't recognize or affirm those folks in care. And I would say an overwhelming majority of youth, even more so, are going to be dealing with that, with just having to act. How does a member of that community access services in a invalidating environment, in an environment that's invalidating to their needs? That's going to be the most common setting that you have in St. Louis. Even though the city is increasingly progressive, I don't see a huge amount of services that are specialized in the same way that you would see in Boston, San Francisco, Chicago, and more developed out states, because some of that has to come at the state level, which is, you know, can be very challenging when you're in a state like Missouri. There's a question here. I'm looking to reach. Oh, I'll let other people chime in, and I can always chime in as well. Book recommendations for readings. I share a reading list with students at the end of the semester, books that could be useful. Pretty soon you're going to be wishing you had free time to read books on your own. Pretty soon you're just mainly going to be reading things that people tell you to read. And that, I got my PhD 2 years ago, so I'm not too far out from having that feeling of being like, and then when you're done, you're like, oh, thank goodness I can read whatever I want now. Okay. I mean, we're 2 minutes. We're pretty much at the end. Well, thank you, everyone. This was a great opportunity to get to know folks. And if you have further questions, I hope to see you in my class and get some time to relax before everything gets busy in the fall, because it's gonna ramp up. So you should take this summer to really relax and breathe and just chill, because it's gonna get kind of wild during for 2 years. It'll be pretty busy. So.
And I wanted to say also to feel free to email the Brown Admissions Office for any questions that you may have. We are more than happy to help you. And thank you all for joining us today. It's lovely to see everyone again.
Okay. And congratulations on this next step. All right, take care.